welcome to everyone, and thank you very much for spending some time finding out a bit more about Newcastle University Medical School and a bit about tonight's talk, which is all about life in the emergency department. So I'm a consultant in the NHS. I'm an emergency medicine consultant and have been for over 15 years now. And I thought it'd be quite interesting just to have a think about what life is like as a consultant, what life is like in emergency medicine. It's obviously one of those specialties that is often people know quite a bit about because they've either been through it themselves or seen things on TV. And yeah, I'm not going to be precious about anything. I'm going to tell you exactly what it's like. So you kind of get a sense of if you apply for medical school, one specialty that you might head into as a permanent part of your career. But it's also one of those specialties that a lot of people will pass through as part of their training because it's such a rich environment for many different things. Lots of people will pass through for 4 or 6 months to get experience in emergency medicine. So let me just get my slide set up. There we go. So yeah, as I said, I'm a consultant, and also I forgot to say that I'm also work quite closely with the university as a personal and professional development tutor. I run sessions once a week with various different year groups, thinking about how we sort of manage different professional aspects of student life, preparing people to be fully fledged doctors. So this is the emergency department I work in Cramlington, which is a few miles north of Newcastle. This is it when it opened 11 years ago, and this is the front desk before anyone actually came to it. And what I want you to imagine is that it's 11 o'clock at night, and this is a busy, full department. And I've come on to start my shift, my overnight shift at 11 o'clock at night. And I'll be taking over from 3 consultants and a team of doctors and nurses who are going to tell me all about the department. And on this particular night, it's very busy. This is the ambulance corridor, and there are lots and lots of people around. We have cubicles for about 40 patients, and currently there are 80 patients in the department. Not all of them will be in the corridor. A lot of those people will be in the waiting room because they're well enough to sit and wait to be seen. But I'll be told about each of those patients, what we know about them, what's going wrong with them, what the plan is from an emergency medicine perspective. Some of them will be seen and be waiting to be admitted formally to hospital. Some of them will be waiting to be seen, perhaps not even being triaged, so we don't even know what's wrong with them yet. So I'll be told about those patients. I'll also be told about what is expected to be happening over the next hour or so. And I'm told that there is a patient who's about to come in who's in cardiac arrest. And ideally, we'd want to put that sort of person into our resus area, 4-bedded resus area where we see the sickest patients. Unfortunately, that resus area is full. So I've got to find space for this acutely unwell patient. But I've got 4 other really sick patients in that room where I ideally want to treat this person. I'm also aware that it's very busy and that we're going to keep getting ambulances coming through the night. So I've been told that the ambulance service are keen to make sure they know their ambulance drivers and the paramedics can bring in patients and offload them safely into a safe department. So I've got quite a lot going on, and I've got my team with me as well. So I've got a big team working. So even overnight, when we are at our lightest from a team perspective, I'll have 10 other doctors and I'll have 20, 25 nursing staff, as well as porters, radiographers, physiotherapists working as part of my team. So it kind of gives you a flavor of what emergency medicine is like. Lots and lots of going on, lots of acutely ill patients, lots of very quick decisions to make, but a big team to work with. And that's what for me makes it really interesting and a nice thing to do. So I'm using a lot of my medical training and understanding of acute medicine, but I'm also using a lot of my communication skills, leadership skills, teamwork skills to be able to manage this situation. This is an infographic that was created by the College of Emergency Medicine a few years ago, just bringing together all those different words that people associate with working in the emergency department. And you kind of get a sense of some really nice things in there about how stimulating and rewarding work in emergency medicine is, but also is there some things in there where it can be exhausting. It can be quite frustrating. It can be put people right at the edge of what they feel is capable of what they're capable of doing. And one of the things with emergency medicine is that it's one of those specialties that people are very aware of. Like I said right at the start, some of you may have been in an emergency department because you've been unwell or injured. You may well have had relatives or friends who have been in an emergency department. And also, it's forever portrayed on TV and films in various different lights. And it's one of those things because we're the front-facing part of the NHS that we're often in the papers a lot as well. So you may have some understanding a bit about emergency medicine. You may read about the sort of pressures or hear about the pressures of working in emergency departments. And that can be quite interesting to kind of have that sort of difference of opinion about what is out there in the real world and what we actually see day to day. But even within the world of medicine, people kind of think, oh, if you work in emergency medicine, it's all cut and thrust and all very exciting. And we certainly are trained to manage some rather interesting scenarios. So I'm going to show you a few pictures. I'm hoping because you're thinking of applying for medicine that you're not going to be too squeamish. But if you don't like some blood and guts, I've just got one slide that I'm going to show some pictures on, which if you are worried about how you might respond, just turn away from the screen for a short while I talk through these things. So in emergency medicine, we need to be prepared to act very swiftly within a couple of minutes for literally life-saving procedures. And that's some of the things I'm going to show you. And this is all training for rare events. So firstly, people give birth in emergency departments. That happens not infrequently, and I've certainly delivered a couple of babies in my time. But one of the things that we're trained for is that if someone who is pregnant is involved in some kind of accident or is medically very unwell, and they are pregnant, if their heart stops, we have to do everything that we can to resuscitate the mother and their baby. And one of those things might be doing an emergency cesarean section. So I'm not trained in obstetrics, that's a field of medicine where we deliver babies, but I'm trained if someone is very near death or actually in cardiac arrest to be able to do a quick cesarean to try and save mum, but also to try and save the baby as well. One of the other things that we do is if someone has problems with their breathing and has an obstructed airway, that can happen for a number of reasons, is very quickly, you've probably got about 2 minutes to make this decision, to be able to make a cut in someone's neck, to be able to get to their trachea, their windpipe, to be able to help them with their breathing. It's not all about life-saving surgery. This is saving someone's eyesight. So this is called a lateral canthotomy. And if someone has a buildup of pressure behind their eye, especially after trauma, they may have a big bleed behind their eye, builds the pressure up around the eye, and they can lose the sight in that eye. So part of what we do in emergency medicine is being able to recognize that and do this eye-saving surgery. And you've got about sort of 10, 15 minutes to make the decision and then actually do this surgery. And then something that often ends up being on TV, this is called a thoracotomy. So this is opening up someone's chest, usually because of trauma, to get to their heart or lungs or the great vessels, the aorta going through the middle of someone's chest, to be able to treat any severe acute bleeding or thorax problems that are causing a threat to life. So all those things I've been trained in, I'm happy to do. The only thing of those I've actually had to do in real life is a thoracotomy. So it's a really weird situation of being trained to do these things, but they are rare, but we don't know exactly when they're going to happen for any one individual. What is far more common is managing something like this. So this is me on the 30th of January, 2020. Now, you'll all be aware, obviously, of the COVID pandemic five and a bit years ago. The lockdowns all happened at the end of March. The first identified case was at the end of December. And so here we are. This is a month into what we were fairly sure at this time was going to be a worldwide pandemic. And this is me putting on some PPE for the first patient in the Northeast that potentially had COVID. And at that stage, that we thought it was a very highly contagious disease, hence all the PPE. But also we knew that it had a high mortality. Now somebody needs to see this patient and assess them. And I was the consultant on the day when this gentleman pitched up to the department with flu-like symptoms. And it's one of those things that you perhaps don't think of having to do in the UK NHS, putting yourself in a position where I knew I had the right protection, but we didn't know much about the disease at that time. So this was me prepping before I go and see this patient with a disease that we didn't know much about. But that's part of the excitement of emergency medicine is all the potential for these things, and clearly they don't happen every day. But it's something that we need to be prepared for, and you don't have time to think about it. Can't go away for a couple of days and have a think. You've got to make really swift decisions. So it's very much a field where people have to be comfortable with their decision making. I showed you this picture earlier. This was taken by a paramedic at the height of one winter when we had a lot of people around in the corridor. And this can be a very frustrating aspect of medicine, but this is the reality. It's not all blood and guts. These are all people who have come in with various injuries or illnesses and are at the front door of the NHS where they want help. They've got friends, relatives with them. But we have no control over who comes into the department. Anyone can phone for an ambulance. The paramedics will be able to triage people into different directions, but if they need to come to hospital, they will come to us. And as well as that, we've got an open front door, so anyone can come into an emergency department any time of day or night. And that's the reality of dealing with this unpredictable number of patients coming in with any number of different medical problems. So that's a challenge, but it's also one of the joys of working in that setup. So I forgot to say, if you did look away because of the squeamishness, please look back. There are no other gory pictures. Excuse me. So one of the ways, as you can imagine, working as an emergency medicine consultant is that I'm looking after this department with a lot of people, a lot of members of my team, and I'm trying to solve this continuous Sudoku problem, but people are putting in numbers, taking away numbers, moving the whole puzzle around. And that's a real challenge. So like I say, at the start of this night shift, 11 o'clock at night, I've got a very busy department. My first challenge is to find space for this patient who's coming in a few minutes in cardiac arrest. But I've got to do that safely with the other patients who are really sick. But also I've got a load of patients in the waiting room who I know nothing about, maybe be quite unwell. They may have minor injuries that need a quick turnaround. So I'm constantly problem solving and using my medical skill to make decisions about how to manage all those cases. And as I said earlier, it's a lot of teamwork. I'm not doing all that by myself. I'm relying on my team, working with members of my team. We're working as a unit to get the best that we can out of the situation that we're in. Now, I come from a non-medical family. No one else in my family has gone into medicine. And despite all these years in medicine, and especially in emergency medicine, they don't really understand what emergency medicine is like. There's a temptation to think that it's all about injuries. This is an old diagram called the Wounded Man. It's from 600 years ago. And absolutely, people with a load of injuries, not necessarily some of the ones that you'll see on there. Uh, the way that those are managed in the NHS, whether you have private healthcare or not, whatever your age, whatever your problem, you will end up in an emergency department for an injury. So we are the place in the NHS where we see that. So that's often in people's minds about how emergency medicine works, but also it's alcohol. That is what is foremost in people's minds about why people end up in A&E. The effect of drinking alcohol acutely, so they've been drinking too much and got into a fight or fallen over, but also the longer term effects of alcohol can have cause lots of reasons for people to end up in the emergency department. So this is what my family think I do: people falling off ladders and people who are drunk. And yes, I do see a fair number of those. But I thought it'd be useful to go through a few cases of some other types of people that we see, because it's not just all about those types of cases. So I'm going to take you through a few cubicles and show you some clinical things that hopefully you'll find of interest. So if we go into the first cubicle, I've got an 11-year-old called Neve. And one of the things about emergency medicine is you cover children and adults. There are many specialties within medicine where you may just see only adults or you may only see children. But emergency medicine is one of those where you see people of any age, from people literally just born, as I've said, all the way through to being much older. So this is Neve, who's 11 years old, and she's fallen awkwardly on the trampoline, and her elbow is very sore and swollen, and that's why she's come into the department. So as part of finding out what's wrong, we take an X-ray. And this is an X-ray of an elbow, and this girl is 11 years old, so her bones are still growing. So this bit here is a normal part of what a bone would look like in this age. That's part of the bone growing, getting more calcium in it, so it shows up on the X-ray. But I need to know that, so I know that that's not part of a break in the elbow. Further up here, got one of those subtle things that you sometimes see. This is a black stripe next to the bone, and that's telling me that there's some fluid in the elbow joint. And for there to be fluid in the elbow joint, there's usually a significant injury associated with that. So that's a subtle sign that I need to look out for. And then we look here, we've got this sudden step in this bone, which is the head of the radius, which is up near the elbow, and that bit is broken. And on this view on the right-hand side of the screen, that great chunk there should be sitting more upright, should be coming up more in this direction, pointing towards the rest of the elbow. So that's a break in the elbow. So I need to identify that, make sure she hasn't got any other injuries. Then we need to fix that. And for something like this, I would refer through to the orthopedic surgeons on call, because you'll probably need an operation. But there are some injuries where we will fix them in the emergency department. We may need to manipulate a joint so it's back in the right place and then put it in a plaster cast. So that's the first patient. Second one is in the next cubicle. It's a 25-year-old called Fergus. He's been out on his bike. He's not been wearing a helmet, and he's fallen off and he's hit his head on the curbside. And he's coming because he's got a headache and he's feeling sick. So you don't need a huge amount of medical knowledge to know that that's probably not a good thing if he's got a head injury and he's not feeling very well. So we're going to get a CT scan of his head. This is a normal CT, just gives you a flavour of what it should look like. And then this is Fergus's CT. So on the right-hand side of the screen, you've got this white lens shape swelling in the brain, and that is a collection of blood. And actually, this is the midline of the brain, which is all pushed off to one side. So that bleed is having a pressure effect on the brain and pushing the rest of the brain over to the other side. That's a neurosurgical emergency. But it takes time for that person to be able to get ready for theatre, to have an operation. So what we'll do in the emergency department, as well as identifying it, is to stabilize him, make sure everything else is optimized so we can go to surgery safely with the neurosurgeons. And that may mean that he needs to be transferred to a different hospital. So Northumbria, where I work, we don't have neurosurgery on site because it's a very specialist area. We'll have to transfer him to Newcastle. So part of our role is to make sure that he's stabilized and is safe for transfer. We need to do that as quickly as possible because the longer he has this bleed pressing on his brain, it's going to potentially cause some longer term problems. Okay, let's go into the next cubicle and see what's happening in there. So this is Sarah. She's 43 years old and she's had a cough for a couple of days and her throat is a bit sore. So, unfortunate fact of life and the way the NHS is that if she feels she wants medical help, she can just walk into the emergency department. And that's not ideal. And we will absolutely see anyone who comes in, but we need to make sure that we have a triage system. So there's two previous patients don't take do take priority over someone who's simply got a bit of a cold. But also we need to think sometimes people can have a cough and a sore throat, and they can have quite significant medical problems wrong with them. So I need to make sure my team aren't dismissing something like this, and that we are looking for signs of more significant illness. You may well have seen something like this where you get advice about where to go. So a lot of these things can be dealt with by pharmacy, by GP surgeries. There's a 111 number to call for advice, and ideally A&E is for emergencies. But all those other three areas, they're not open 24 hours a day. So if they are closed, or if 111 advises you to go to A&E, then they're going to come to us. So we're the kind of backstop for the NHS, which is a really nice position to be in, but frustrating if someone wants medical help for something that doesn't need to be seen in the emergency department. But like I say, we will always see everyone, and that makes quite a nice change. One of the big things about A&E is the variety. So if I've seen these patients in this order, to have two patients who have got quite significant injuries, to see someone with something quite simple is a nice change for me and the rest of the team. So we'll see her, advise her, and then move on to the next cubicle. And in the next cubicle, we've got Albert. He's 82 years old, and he's telling me that he's got some pain in his chest and he's feeling pretty unwell. So one of the things that we'll do to find out what is wrong with Albert is to do a tracing of his heart called an ECG. And this is what a normal ECG looks like. And Albert's ECG looks like this. And it's one of the jokes I always say in emergency medicine is that you don't need to be very clever to be in emergency medicine. I'm hoping that you can spot the big difference in how those two ECGs look. The one on the left being normal, the one on the right is showing someone having a particular type of heart attack called an ST elevation MI. And it's called ST elevation because these bits here in this lead and this lead and this lead, these are all looking at different areas of the heart. You can see how you've got this big jump up here, whereas on the one on the left, it's nice and flat. So very easy diagnosis to make. This guy is having a heart attack, and we need to identify that quickly. So we need to have systems in place to be able to pick this up quickly and get him good treatment. I mentioned a bit about teamwork, and this is based on one of my first weekends on call as a consultant. I'd done all my training to be a consultant in emergency medicine, and on a weekend, I was busy doing something else with another patient, and one of the healthcare part of the member of the nursing team came through and said, "I've got this ECG, I'm worried about it." And what had brilliantly happened is this guy had walked into the department, and the people at reception that you see at that desk that I showed you right at the start said, "We're not happy with you. You need to come straight in and see one of the nursing staff." They're not clinically trained, but they obviously have a good eye for when someone is potentially very unwell. So they've identified someone's not very happy. The nursing staff have brought this person through and found a cubicle for him. And then one of the healthcares has done this ECG. And even though they're not trained to look at ECGs, they know that it's something that doesn't look right in the context of someone having chest pain. And they know that they need senior input in the form of myself to make sure the right thing happens. I see that ECG, know that he's having a heart attack, and know that he needs to see the cardiology team. But I'm in the middle of seeing a couple of other patients as well. So part of that teamwork is I'm going to ask one of my colleagues who's still in training to go and see the patient, make sure he has the immediate treatment he needs before being referred to the cardiology team, who are going to take him off to the catheter lab, where they put a small tube into the blood vessels going to the heart and unblock the arteries that are causing the heart attack. So a really nice example of how we work together as a team. Each of those people play a really important part, and it's easy to think as a consultant, I've done all that training, it's all about me, but it's not. It's all about the individuals that we work with to make sure that things like this can run as seamlessly as possible. Okay, so he's all sorted. We're going to move on to the next patient. And I've put a picture in here of Edith. So she's 72 years old. She's frail. She's got a number of long-term medical problems. And she's been quite unwell for a week, but she's a bit embarrassed about getting any help. She thinks she'll maybe just sort of pull through. She hasn't got any family nearby. And yet this evening she's collapsed on the way to the bathroom. She's been unable to hold herself up and she's fallen down. So this is an example of probably the most common type of patient that we will see in the emergency department. People who are old enough to have a number of long-term chronic problems, and then they've become acutely unwell, but maybe we've missed something earlier in the week. We, as in society, could we have picked this up any earlier if she wasn't feeling quite right? Could she have gone to see a GP? Could she have discussed with her family about how she was feeling? Could she have gone somewhere else if she wasn't feeling quite right? But things have come to a point where she's then collapsed. So if I see her in the emergency department, there's so many different things that could be going on with this. So firstly, I need to think what acute problems are going on, what things have happened this evening to cause her to collapse. Has she been developing a chest infection that's got that much worse, and she's collapsed because of that? Or has she got a problem with her heart? If she's got a number of chronic medical problems, has she got heart failure that has just been getting worse and worse and caused her to collapse? Or maybe there's a problem with her lungs. Has she got a clot in her lungs? All these different things I need to think about and try and hunt down exactly what's going on acutely. Maybe there's nothing acute going on and she's collapsed just because she's a bit weary, because she's been a bit unwell and because she's had these chronic medical problems. So if she's not acutely unwell enough to need to come into hospital, I need to make sure that if she's discharged safely. So I need to make sure that everything else is managed as best as possible. So what is her social situation? Can I arrange for anyone to come and stay with her at home while she's not feeling quite right? Does she need some physiotherapy to make sure she's safe up on her feet, that she's got strength in her legs, and maybe that's contributed to the reason that she's collapsed? Also, she's collapsed on the down onto the floor, and even from standing height, she may have some injuries that I need to find. Some minor problems, nothing like the big injuries that you've seen earlier on, but maybe she's got some injuries that are just going to be enough. She's broken a small bone in her wrist. Maybe she won't be able to use her Zimmer frame, and that will have long-term consequences. So I've got to be really vigilant about trying to find all these different things. And then, as you'd expect with people, as we all get older, more likely to develop new diseases, and potentially there's something new going on. She got a cancer that's only just sort of made itself obvious by being unwell and her collapsing. And so I can go in a number of different ways with this patient. There's the acute problems, there's managing the chronic problems, there's thinking about the social situation, and there's thinking of any undiagnosed problems that may have contributed to this. And intellectually, I find that really fascinating and interesting. She's got up that morning, wasn't expecting to come into the department, and then a number of things has happened, mean that she's going to end up with us. And myself and the team have to work out the best way that we can place her in a very short period of time. As I explained earlier, it's not just Edith, but all these other patients. The ambulances are going to keep on coming. So I need to make sure that I'm treating her appropriately and safely. That's a real challenge. And as I alluded to earlier, you'll see a lot about A&E in the papers, and that's because it's one of those things that is heavily influenced by government policy. And you may be aware of the 4-hour target. And to put all those cases into context, from the time someone comes into the emergency department to when they are discharged from the emergency department, and we've found out what's going on, we've treated it, and they've left that department either to go home to another hospital or to be admitted. That's 4 hours. So we've got all those patients coming in, and we've got a target of 4 hours to be able to turn everything around. As you can imagine, that's quite a challenge. But we make sure that we are not too bound by what the government is wanting, because we want to make sure that we are picking up the people who are need our urgent help. As I've explained, there are a few people that come in that don't need that urgent help. It doesn't matter if they wait a bit longer, as long as we are picking up the people who are acutely unwell. So that's a bit about life in emergency medicine. I thought it'd be useful just to think about life as a consultant. I know that's quite a few years away for you guys if you decide to come into medicine, but just to give you an example of some of the other things that you can do. Because emergency medicine is all about shift work, it means it's quite easy to put other things into your working life. So this is me in front of Cramlington Hospital, and I was part of the team who helped design the hospital. I'm no architect, but they needed clinical input, clinicians who are going to be working in the department to make sure that we designed it in a way that was going to be useful for us and the patients that were coming in. So I had a couple of years being part of the team that were putting all that together. As you'd expect with emergency medicine, we deal a lot with the paramedics, and this is me when I had a few jollies on the Northeast ambulance and air ambulance on the helipad. I'm a bit scared of heights. I'm not a big fan of being in helicopters, but it was really nice to see these guys at work and appreciate what they have to deal with. Very similar to what we have to deal with, but out in the cold and dark, picking people off roadsides and off hillsides. And a lot of my colleagues do some of that pre-hospital work in those acute areas. The other thing that I was involved with because of both those things was a bit of social media. Now, I'm no influencer, but I was asked by the hospital to do some things on Facebook through our communications department to try and make sure that people were coming to the emergency department appropriately. And weirdly, just through this slightly odd video from a few years back, 65,000 views. I didn't realize my mother could watch the video so many times. But yes, something that I wasn't really expecting to do, but it's part of that front-facing aspect of emergency medicine that we'll often end up having to give media talks about people that are in the department or the state of the department if things are particularly bad. This is a spider diagram I put together just of all the different consultant roles that we had in our department. So there are loads of different areas that you can get involved with. Lots of different clinical areas that are important that link into the emergency system. There's managerial roles. So I had a few years as one of the clinical managers in the department, and a lot of that about leadership and communicating with a team. And now predominantly I'm involved with education down the bottom right. So loads of different courses, lots of different ways that we need to make sure the people that we work with are being trained properly. And that's not just doctors, that's members of the nursing staff, physios, lots of people will rotate through emergency department to get an understanding of how we work. So we're responsible for all that training. A few other things I've been involved with. So I mentioned a bit about pre-hospital work. So there's the cut and thrust pre-hospital work going out on ambulances and in helicopters. I prefer slightly easier work. So this is the Stadium of Light, which is Sunderland's football ground. Apologies if anyone's a hard and fast Newcastle supporter, but I do some medical work there as a crowd doctor. So I'm not looking after any of the players, although that is something that some of my colleagues in emergency medicine do, work as sports doctors for sports teams. But I'm there as a crowd doctor. So there are 50,000 people in the Stadium Light Stadium, and I'll be working with a team of paramedics on any one match day to look after them if anyone has any acute problems. As well as football matches, this is a concert. This is Pink from last year, I think maybe it's the year before. So again, same stadium, A lot more people there. I think we had 70,000 people there, and you can see in the bottom there, a huge team. They are just looking after people on one half of the stadium floor. So another group of people on that side. We had three doctors covering this event. And it's just nice. It's a different way to go to concerts and things, but also get a different sort of feel for emergency medicine work. I do some amateur sports events as well. This is a Spartan event where we'll look after amateur athletes who do these obstacle courses. And the place that we work in, far less salubrious than the new hospital that I showed you, but in a tent with a, a very sort of makeshift setup. But it's good enough for us to be able to treat people with the injuries that you can get from these courses. So as we come to the end, a sort of summary of what I feel it's like to be an emergency medicine consultant. I feel like I'm observing all these different screens, but as you can see at the front there, uh, five screens where I just really need to focus. Sorry, I should explain. That's not me. This is an emergency department. This is just a way of thinking about how we work. That there's all this stuff going on that you need to be aware of, but you can only really focus on a few screens at the front that are going to take up your full attention. And I need to be able to jump in and out of all these different areas at any one time, and that gives that sort of thrill and the variety of that type of work. Certainly, as far as the type of person, you need to be quite resilient. You need to be comfortable working with teams. That decision making, which I've mentioned a few times, and it's very fast paced and very complex. So to be able to work in that setup, you've got to be very supportive. It's important that you're approachable and can communicate well as we go through. So I thought I'd finish off just with a little quiz. You don't need to answer, just think in your mind if you can think what answers you may have to any of these questions. Think, which animal have I seen in the emergency department on a shift? The answer is, of course, all four. So before we moved to the new hospital, we're in quite a rural area, and a horse got loose and managed to get into the department. We've had dog, I have lots of dogs, support dogs coming in. We have had a parrot that flew in. I still have no idea where it came from, but funnily enough, having a parrot flying around when you're trying to treat patients is not very easy. And when there was some flooding, one of the reasons we moved to the new hospital, we had a frog in the department. So I've seen all four of those in the department. Phrases that I have genuinely heard over the past years. I'll let you work out what was going on for that first one. I've had people with psychiatric problems telling me very convincingly that they can see dead people walking around. I had someone think their child had rabies because he won't have a bath. If you want to look more into that, you'll Google rabies and water. And various things that people get stuck in various other things that we need to get the fire brigade to help us get cut off. Unusual diagnoses that I've made. So someone came in with what they thought was a rash. They were concerned it was meningitis. It turned out to be raspberry jam, so we could just clean that off. Someone was concerned about a black spot low down in their eyelid, and that was a tear duct. I was happy to reassure them that they had one on the other side. Someone once came in and they were blue, and this was around the time of COVID, and they were very worried that they were blue because they didn't have enough oxygen. Turned out they'd had some new sheets on their bed, and it just rubbed off on them, and therefore they turned blue. And another medical thing, ulnar styloid. If you look on your wrist, you'll have a bump. Just follow down from your little finger, you'll have a bump on your wrist. And we've all got those. That is called your ulnar styloid. And I've had several people over the years come through worried about this new bump on their wrist because they've just not noticed it before. And finally, one of the strangest evenings I had was when someone came in holding a bone that looked similar to this and wanted me to tell them where it had come from. And so this is a policeman who came in. Someone had found it in their garden, phoned the police, and the police needed to know whether it was human or not, because if it was human, then they had to treat it as suspicious and a potential murder. But it could have been from an animal. And funnily enough, I'm used to seeing these, but usually attached to people, so I wasn't able to help them. But it just sort of highlights that thought that people come to the emergency department with anything and everything. If you want to know more about emergency medicine, and this is absolutely genuine, of all the TV programs that are out there, 24 Hours in A&E, all the various series have been the most true to life that I've seen, because they show it warts and all. They'll show the people sat in the waiting room having a chat, and then they'll show you the major traumas that come in as well. So if you want to get a feel for what it's like, genuinely recommend 24 Hours in A&E. If you'd rather read, this is a book that's been out for a few years, called In Stitches, but it's very readable, with some good A&E stories in there. So, just to summarize, if you work in emergency medicine, lots and lots of opportunities within emergency medicine. You can pass through as part of your training towards other specialties. But also, if you work solely in emergency medicine, lots of opportunities to do other things as well, which hopefully I've described. It is very hard work. It's shift work. That's not for everyone, but it is incredibly rewarding. Partly because you will see anyone and everyone, and you'll see them at their absolute worst, for them to end up there, but also at their best. You see that real commonality of human spirit. And I will finish with the last slide of sunrise over the ambulance deck at Cramlington. One of the reasons why I really like emergency medicine is that I can finish my shift. A new day is starting if it's a night shift, and I can walk out and I have no further responsibilities. And I have to live with the decisions that I made and what has happened previously, but I don't keep worrying about my patients because I no longer have responsibility for those patients. So I hope that was a useful chat about life in emergency medicine, and give you a bit of a flavour of the kind of things that you can do if you choose to do that as a career.